for us, 15 kilograms of lead that we have to wear because of those X-rays under 28 degrees, you may accept that those conditions are not very satisfying when we talk about stress and intervention. But still, when we achieve a good result, it's always the same. We forget everything about the intervention. So what about aneurysm? If we talk about children, we talk about a different pathology because those aneurysms are mostly large. They are distally located, fusiform, so that the entire artery is diseased. And it means that the treatment is, of course, more difficult because it's not a sac that you have to occlude. That's what we do in young adults and in every patient, but not the children. But when we talk about children, it's a different type of aneurysm. Mostly, it's a disease of the brain vessel, and that's what we have to face. So giant aneurysm of the basilar trunk involving the vertebro-basilar junction. And also, those presentations are different from the adults. Of course, we have bleeding, we have subarachnoid hemorrhage, but we have mass effect, we have stroke, and of course, the risk of bleeding and the prognosis is very poor if we don't do anything. So this boy was coming from Algeria with this giant aneurysm of the basilar trunk. And the best treatment is not to use stents. We can use stents in many different pathologies, but the best treatment when you have something giant is to occlude the vessel. That's the best option to decrease the risk of recurrence because the disease is on the vessel wall, and so it might recur. When you occlude everything, the chance of recurrence is very low. And that's what we did in stage treatment, of course, was to occlude first the right vertebral artery and the junction with the basilar trunk, to let the boy for a few days rest, and then to do a basilar trunk test occlusion. And this is how we do. We inflate the balloon in the vertebro-basilar junction, and we control via the ICA and the PCOM if we have a good and satisfying opacification of the basilar trunk. That was the case, and so we could, based on those criteria, occlude completely the basilar trunk until the end of the aneurysm, and this is the 1-year control with a quite impressive shrink of the aneurysm, and the patient was free of symptoms. This is an acute case of subarachnoid bleeding. You see that the aneurysm that is responsible for this bleeding is very special. It's not even a sac, it's just a small tear of the vessel. That's what we call blood blister-like aneurysm. If you want to put a clip, you will rupture the artery. If you want to place coil, it's really too small and it's very fragile. So the only way is to put stent. It will modify the flow to occlude progressively this aneurysm, and that's what has been done at the acute stage, so giving the patient, of course, antiplatelet therapy, despite the fact that he had a bleeding, but we had no other solution to treat him, and it's quite conventional now to do this in those cases. And this is the control at the end. You see with the occlusion of the aneurysm, some modification of the arteries because of those flow modification induced by the stents. This is quite quick, and we heard about port wine stain and venous and lymphomatic malformation. That's also something that we do by percutaneous access, injecting some sclerotic agent to decrease and to make those malformations disappear in different locations. Can be mandibular, it can be superficial, and in most cases it's cervical region, meaning that the blood vessel going to the brain might be involved, and that's why it has to be done by interventional neuroradiologist, I think. Last but not least, and I won't talk a lot about that, but you probably know that the biggest, I think, revolution of therapy in a big field that is stroke has occurred a few years ago with the publication of those studies showing that intracranial thrombectomy is the first-line treatment of patients with acute occlusion of a, let's say, big brain vessel like MCA, ACA, ICA, basilar trunk. And there is no big difference if we talk about children, even if the occurrence, the incidence is very low. There are no trials with children, but what the literature is saying that the benefit of intracranial thrombectomy is the same when compared to adults. So that's a daily job as well. Even if we don't have many children with stroke, they would be considered as an adult to be treated by intracranial thrombectomy. To end, that's what we do in Erasmus now. We have a dedicated interventional neuroradiology department, meaning that we only do angiography, I mean diagnostic one, interventional therapies. And we have around 100 cases, 100 procedures of pediatric and neonate patients coming from different countries. And of course, it's only possible because we have this team, and I insist on that because of all these persons working in this dedicated and very unique field of interventional neuroradiology. Thank you very much.
Thank you very much for this fantastic and very nicely illustrated presentation. Paper is open for discussion. Please.
Do you have any experience in interventional vascular treatment of vasospasm? Thank you. Very sophisticated, yeah, impressive. Do you have any experience in treating vasospasm after subarachnoid hemorrhage endovascularly in children?
Yes, we have. It's not different from adults, so it means it's one of the treatment, but it's of course the last treatment. No real trial showing its efficacy, but we know by daily practice that it works, that if triple H therapy does not work, and if we have a focal abnormalities on ultrasound or whatever imaging technique, we can do injection of intraarterial nimodipine. If it does not work very well, we can use balloons to dilate. And so for us, it's not different to treat children or adults. So yes, that's what we do. And in emergency, of course, you have to treat as soon as possible. And we know that it lasts for 6 hours.